Thank you all for coming. This is the IPEC event held by the Addiction Medicine Club, the Family Medicine Club, WADM, and the Anesthesiology Club. So thank you all for hosting. We have Dr. Meredith Norris, Dr. Mokler, Matthew Braun, and we might have one more speaker coming. So you guys can feel free to grab some lunch. I think we're just getting the rest of it now, so feel free to just get up when you would like some. So we're going to first show just a short film to set the stage, and then we have a series of questions that we'll go through for our speakers. And this is supposed to be very interactive, so feel free to chime in when you want to add a point or ask a question. And yeah, so we'll get started.
Know someone in recovery. The problem historically is they didn't know they were in recovery, which means they could continue to maintain incredible stereotypes about who are the people who develop alcohol and other drug problems in this country and who are the people who recover and don't recover. There are a lot of issues around stigma that I can't educate you out of. I can give you all the facts. I can read all the books to you. I can show you documentaries. And nothing's going to change that embedded prejudice until you encounter personally someone in recovery who means something to you and hear their story. I'm one of the most out people probably in this country. And I can run around with my big Recovery March t-shirt, right? And I get home from a march and my dear wife Rita says, "Can you run to the store for me?" And I say, "Sure." And without thinking, now this is decades now, I pull my recovery t-shirt off and throw a sloppy old plain t-shirt on, and I'm about to walk out the door, and all of a sudden it hits me, what the, I won't say the word, what did I just do? And all of a sudden you realize this stuff is insidious. You know, that it just keeps creeping back in. That I'm okay as a person in recovery when I'm surrounded by 15,000 people in recovery. But I'm a bit embarrassed to walk down the aisles of my local grocery store with the Recovery Celebration t-shirt on. That's how insidious some of this stuff gets to be. Obviously, the call to action we are making is not for everyone in recovery to go public with their recovery status. Stigma related to alcohol and other drug problems is still very real in this country, and people can experience significant consequences by disclosing parts of their addiction and even their recovery status. So what we are looking for is a vanguard of people in recovery who are temperamentally suited for that role and whose personal and family circumstances allow them to take on part of that public role, to simply step forward and put a face and voice on recovery. And as soon as we begin to get this vanguard to step forward, those stereotypes simply can't be sustained any longer. And as the stereotypes begin to disintegrate from this advocacy effort, then what we can do is come behind that with our advocacy and begin to dismantle the discriminatory structures that really have created obstacles for people seeking and maintaining recovery over time, and building resources that are going to dramatically widen the doorway of entry into long-term recovery for people. We could barely fill a shelf in our addiction studies libraries with what we know about the recovery experience, but we can fill whole buildings about what we know about the pathology of addiction. We have millions of people in long-term recovery in the United States. It's time we began to study the solution to this problem as opposed to study the problem. I was going to Dallas, Texas. I was going to speak at a professional conference, and I visited one of the old-timers in the recovery community in Dallas, Texas, CW, and I was interviewing him about the early history of treatment in the Southwest. And I'll never forget Circe, when we took a break in the interview, Circe said, "Now, Bill, what's this research stuff you do?" And I explained to him that what I did for a living was I worked in a research institute, and we studied treatment by doing treatment outcome studies. And I told him that we were going to follow people for 5 years. Now, I'm talking to someone with 54 years of sobriety at this point in time. And Circe just looked at me and smiled and said, 5 years, very impressive. He said, what does your research tell you about people like me? And what do you think I had to say to him? We don't even know you exist. We don't know anything about people in long-term recovery. On the plane home from Dallas that night, I had this powerful experience. And it was this awakening that I had spent almost my whole life learning about addiction. And I felt like I knew a lot about addiction. I'd mastered a fair amount of that knowledge. And I'd learned a lot about treatment. But separate from my own experience from the standpoint of science, I knew very little about the long-term processes of recovery. And so I sort of made this promise to myself that for whatever time I had left in my career, I was going to devote it to the study of the solution. My entire presentation reflects, I hope, a sense that we are on the brink of moving from a pathology paradigm and a treatment paradigm as the center of the field to a paradigm of recovery. What some of you don't know in this room is that some of you will go on in the city of Boston, in the state of Massachusetts, and nationally to help lead this movement. And for those of you in this room, I wish each of you, and particularly those of you who may not know it, but your destiny is tied up with this larger movement that is now unfolding. I wish all of you Godspeed on your journey into this recovery frontier. Down here, people. You want to sit close to us?
Okay. Let everyone settle. Okay, so what we're going to do now is have the panelists introduce themselves briefly. We are going to need to speak into the microphones if you're going to be a panelist or if you're asking a question, or else it's not going to be broadcast out. So I have a couple. Just flag me down. I'll hand them off to you. One sec. So I can get one of these working. Is this one? No. You want to introduce yourself?
My name is Matthew Brown. I'm a person in long-term recovery, and I guess that's all I'll say for now.
I'm Meredith Narisdio, current president of the MOA. Holla! I do have one amendment, which is that the ACOFP is not the Family Medicine Club. It's a pre-professional organization for family medicine. I do what I call recovery medicine in several different parts of Maine and have done so for about 10 plus years. Matthew and I wind up being in a lot of the same arguments on Facebook.
Hi, I'm David Moakler, PhD. I'm a professor of pharmacology here at the medical school. Been here for about 30 years, and much of my research has been more on the pharmacology of drugs of abuse and how they work in the brain. But in particular, those of you who have been in the class with me know that I'm also interested in the behavioral aspects of substance abuse and how that affects people. And I learned very early on in my career, I first started out being very interested in hallucinogenic drugs and other stimulant-like drugs and how they affect the brain. But I found out very early on that drugs do one thing, but it's the people that are using the drugs and how it affects the brain. And then, of course, excuse me, the whole issue of recovery is resilience and the ability to turn it around to resist use of drugs. And there's Dr. Cohen. Come on down.
I was enjoying my first hot shower, sorry.
Here's some water for you and questions.
We're doing intros.
Hi, I'm Hal Cohen. Enjoyed my first hot shower in a few days. I'm a primary care physician for the first 19 years of my career. I was internal medicine and pediatrics. In the last 7 years, I've just been internal medicine. I have no special interest in this, except that it's all of our special interest now. I also act and I playwright and direct. And I had a play that I wrote called Vention, which was a dramatic, bizarre, but based on truths about the opiate crisis, at least in this one family, in this one young man. So I've also tried to take it to the public in a very unconventional way from what we usually do in medicine. So, and then I went to UNE back in 1585 or something like that.
All right, so we can kind of get started with the questions, and again, chime in whenever you want to say something. We'll pass around some mics. And for you guys, you don't really have to go in line. Just if you want to add something, we'll give you a mic. So first one is, why do people feel shame when they have a substance use disorder and seek out treatment?
Oh, look at that.
Yeah, right.
Bilateral. It's not for me to speak about why people with substance use disorder might feel shame, but if you consider how many different levels we give out the message that substance use disorder is a sign of bad moral character, if it's been transmitted in 1,000 microaggressions for years in front of you, the likelihood that you're going to self-identify in a positive way as a person who is interested in recovery is extremely limited. All the little tight faces that people give in the emergency department when someone is on medication-assisted therapy, all the "isn't it about time that you stop that?" I had a med student who's wonderful, wonderful, and the people at her church found out she was working with me, and they said, "So basically this is about a lack of self-control, right?" And the message is everywhere. I'm actually excited when people don't feel shame, because getting sober is hard enough without having to get all that other self-castigation mess into it. Anybody?
I'll share a few different aspects. I'll share mostly all personal aspects, I guess, and first, I want you all to see substances as a solution and not as a problem. And that the way someone like me uses substances is to try to fix something that I think is wrong with me, that the world isn't fixing for me, something that I maybe don't even fully understand. So I find that, and when it works, it works. And I say openly, I used substances because they worked. They were the only thing I found that were an effective solution for my inner pain. And so when I have to seek out treatment or self-identify as that, people saw that as immediately the problem, but didn't have another long-term, permanent, effective solution for me. And so they were just removing something that was maybe working for me without putting something in its place. So I didn't want to get rid of that solution. Also, when I started identifying as having problems, or people identified for me, I grew up in a small town, Cape Elizabeth, and not far from here, and when people found out I was having these types of problems, and especially the district attorney found out, she put in our local papers that she wanted to make an example of me to show the world what happens in a small town when someone like me does this kind of thing. No one wanted to help me. She didn't want to help me find treatment and recovery. She wanted to make me an example, the scared tactic. And so that just reinforced my shame that I can't ever open up about what's happening. And we worry about how we're going to be accepted. We worry about, can we actually effectively live in recovery or live sober, whatever that looks like. And so that adds another element. So it's a terrifying time when we don't really know if something is going to work. And honestly, when you get to feel so low, you don't know if you want to feel better. So it gets so multifaceted, compounded with the fact that society doesn't really understand what we're going through, and sometimes medical professionals don't understand, and sometimes point us, unfortunately, in the wrong directions that aren't necessarily tailored to our needs and our wants. I'll stop there for now.
Feel free to get food, guys.
I would like to piggyback on top of that. As a physician who I've been practicing 26 years, we now are being made to feel shame, because when we had patients like you and we went through all these variety of things, and we didn't necessarily go to an opiate right away, and then that's what we came to the conclusion worked best. We were taught, if you were in medical school just a few years ago, just a few years before now, you would be taught, don't undertreat pain. Pain is the 5th vital sign. Make sure it's a smiley face or a happy face, 1 through 10, over and over and over again. And if you did not treat your patient's pain, you were a bad physician. And medical schools bought into this. The hospitals bought into that. The big pharma came in and taught us, but we also bought into this. And I got to tell you, when we found something that took our patients out of pain, it's highly rewarding. Highly rewarding. And as a primary care physician right now, who I'm part of this problem of creating it, I'm angry. I'm angry because I am made to feel shame now of what I did. I'm angry that I am perceived as part of the problem. I'm angry because I know I helped patients. What I'm aware of now, yes, get those doses down low. It's not used it shouldn't be used as frequently as we did. But I got news for you. There's a role for this.
Amen. I would add that now we're having a second wave of stigma, which is that my ladies with end-stage rheumatoid arthritis are getting the same stink eye when they go to the pharmacy to pick up the meds that they've been using effectively for 20 years. And I literally had to have a phone call with the corporate office of CVS, who pointed out, quote, dangerous prescribing habits of mine. And I'm kind of going, well, this is kind of funny, but here's what my practice is. And what I'm usually doing is trying to create a relationship so people can be on less meds. But I explain to them, if something's been working and you take it away, they don't suddenly get into recovery, get into meditation, get into yoga, and now they don't have any more nerve damage. But what many of them do is find some other solution to whatever that problem is, especially when there's so little access to things like trauma-informed therapy and, good restorative health care.
And heroin's cheaper.
Yes, heroin's a lot cheaper. Yeah, we'll just hang on to it.
Yeah.
Anyone have any questions? We can provide a role. There we go. As future healthcare providers, how can we make our patients feel more comfortable speaking with us if they believe they have a substance use disorder and want help?
I just feel like this is either one. Well, I feel like, given that it sounds like the people working with you did a spectacular fail on how they helped you, I feel like this is Exhibit A. But understand that you're batting cleanup for every judgy person that they've ever encountered. And when I have had to talk to people and say, I'm concerned that this isn't working, that maybe this isn't the right medication. And bear in mind, there's people who won't do pain management who will give out benzodiazepines like gumdrops, and that's a thing. Bear in mind you're batting cleanup for that, and bear in mind that many patients have their own, when you say, I think this is getting out of control, your relationship is bad with this medication, what they hear is, I think you're a bad person and you're up to something. And I'm not some junkie. which then gets even more meta because I start saying, please don't call my patients junkies. That's a pejorative term. But it understand that the choice of language you pick is huge. And I think you might have a drug problem is probably not going to have a therapeutic relationship. Remember, you're trying to be on their side and you're trying to help them. You're not trying to say, aha, I've caught you.
So I think that the way to approach this, if you're just getting started in this area, is to really practice, practice, practice. And practice meaning practice having open conversations, practice telling the truth, not trying to hide because you're nervous about it, because you will be nervous about it, but practicing how to have that conversation with any of your patients, not just the ones that you're working with that have chronic pain and may have an addiction problem, may have substance use disorder, working with them. And that's, I think, where Meredith comes from, where Hal comes from, in terms of having many years of experience of being open with patients. And once you become open with patients, then they can feel that. And so you just really need to learn how to do that, and it's not easy. It takes many years to do that.
Let's just switch this up. It sounds like that one's on its way out.
And don't think for a moment that you will not judge. If he came into your office now, you'd pay attention, you'd listen, you'd give him the benefit of the doubt. Now picture whatever you think is the stereotypical person you don't want in your office, whatever that is for you. And if they came in saying the exact same words, I got news for you, you're going to judge. Forgive yourself, be aware of it. You can't solve anyone else's problem or help them solve a problem if you're not aware of your own. So be kind to yourself.
And also do whatever you can to facilitate trust. I mean, that's really been said in so many words by everyone so far. The sort of the unlikeliest of people was my best advocate. It was my arresting officer, detective, who's now a sergeant, and he was really the first person in my life to say, and he was the only person I think who had the he could have gone the completely other direction, but he said, Matt, okay, you've broken into houses, got something going on, but you've got a promising future. You're a good kid. I've known you for a long time. Let's not let this be a barrier. He helped me get into treatment. He's still one of my biggest supporters, my biggest role models. And it was because he had a great attitude. He saw me as a person. And that's it, a person with, sure, lots of things I needed to work through, lots of actions I needed to clean up, lots of bridges I needed to mend. But he saw me as a person, and he said, let's put your record on hold, get help, then we'll address it. You deserve to get help. You deserve a better life. He sat with my pain. He wasn't a trained therapist, but he didn't know necessarily what to help me, how to counsel me through this stuff. But he sat with me and said, I know you're in pain, and I'm willing to be there with you. It almost doesn't matter what you say or whether you know what to do. If you're sitting with someone's pain, honoring what they're going through instead of dismissing it, because even something so insignificant could be the biggest mountain for any given individual. And honoring that they're going through that is the first step towards building that trust. And of course there's going to be a lot of trial and error in working with your patients. It's not necessarily an easy road. There are lots of effective treatments, lots of ineffective treatments. It's highly individualized for each person. Sometimes takes the right combination of lots of different things. Could be medication, could be no medication, but there are lots of other supports that you may not be able to help them with that they're going to need. They need a stable place to live. They need good access to mental health care, other types of wellness that as a primary care physician, they may not be your first go-to, but if there's time, helping them see these other things that they could work on with alone or with their peers or with other professionals. But it really does all come down to trust. And how are you viewing me? Are you viewing me as a person who can get better, or are you viewing me as someone who you don't understand?
Hi, Clay Graybeal. I'm on the faculty of the School of Social Work, and I direct the SBIRT grant here at UNE. SBIRT stands for Screening, Brief Intervention, and Referral for Treatment. One of the things that I think we're always at risk for is medical diagnoses dichotomize the world into either you have or you haven't. But we're all on a continuum. We all use substances in different ways. So part of the way to get good at having these conversations is to have it with every single patient. And that's part of what we do at SBIRT is every patient gets screening, and that gives you an entree to have a conversation about all kinds of things. It's alcohol, it's caffeine, it's nicotine, it's anything that's affecting the person's life. And by doing it with everyone, you get really good at reducing judgment.
The only thing I'll say to that is in the middle of the day where you're seeing 20 to 25 patients, and if someone is coming in for strep throat, you look at that patient as a way you can, that's going to be a 5-minute patient where because you know you're going to fall behind on someone else. You can't do it on everyone. I try to do something like that with everyone who has a physical. So I save my inventory of where I want to catch up on their lives at their physical. So I think you can do it hopefully, and that's why they say, why should we do physicals? You do physicals because you have the time to do all these other things that are so much more important than the exam. The least important part about a physical is the exam. It is things like that.
I was just going to say, I think it helps us see the person as a person and not as a disease, and that a lot of people who come to someone who takes care of people with pain is they're used to being a person with a disease of pain or a disease of a substance disorder. And I think when you look at that, when you can allow yourself to look at that person as another human being who is inherently capable of healing themselves, then that empowers them, and that is a really good educational relationship to have with them.
So I don't want to totally put Christy and Madri on the spot, but do you want to share a little bit of what you found in your research this summer, if it pertains?
Can I share something real quickly first?
Yeah.
Sometimes, though, patients will come to you with, they have labeled themselves. Many, many, many years ago, a patient came to me, and first time I met him, and I went, "Hi, I'm Hal Cohen," and he introduced himself. I don't know if he said hello. I have back pain. I've had back pain for 34 years. He spoke about nothing but pain for about 10 straight minutes. And I said, great. I said, and I addressed that. I spoke about that. I said, I don't know you. I said, the next time you come in, I want you to tell me about yourself. So months go by, and I see him again. Of course, I don't remember this conversation. But he comes in, the next time he came in, he takes out his wallet, and he's showing me pictures of his grandchildren. I had no idea what I said to him last time, but he's going through this, and I'm looking, and he finally realized I have no idea what he's doing right now, and he tells me. But that whole visit, all we did, we just discussed his role as a grandfather and the pride that he had. So sometimes patients are going to come in self-labeled. We've probably done that, but it takes a community to label someone, including the individual.
I've never used this. Okay. So this past summer, me, Christy, Sam, and a bunch of other healthcare professional students and undergrads did research to try to understand the underlying subconscious or conscious attitudes that physicians have towards patients with substance use and how this may affect their treatment. So our procedure was doing a survey, like an online survey, followed by an in-person interview where we asked more questions about exactly like how has their attitudes affected their treatment and the outcomes, like do they have patients with substance use disorder, and how has their relationship grown with those patients. And so we got all positive results, but we were kind of thinking that that was more because the selection bias of who took that survey. So we sent that survey to like 150 physicians. We have 21 responses so far, and everyone who did respond was very willing to share their experience. So this may be just selection bias, but we are trudging forward. So if you know any physicians who want to take this survey, let them know it's out there. You guys have anything to add? Yeah.
I just wanted to add that Madri recruited me for this project, and our role as student researchers was to actually go and interview the physicians and have a conversation with them about their work and their experience. And even though there was a lot of selection bias, I think it was really encouraging for us to talk to people who were so passionate and so inspired about helping their patients and saying, yeah, you're going to have a lot of roadblocks. It's not something that comes naturally to you, but regardless of what practice you're in and who you encounter, you will find people with substance use disorder. And these kinds of events and these kinds of research and work and listening to your stories is helping us kind of formulate how we want to approach people in the future. So I just want to say thank you as well.
Hi, I'm Harmony Stratton. I'm a primary care doctor who's recently moved to Maine because my husband's a first-year student. And I think one of the really strong things is to realize the power of connection when you're treating people with substance use disorder, and to recognize that one of the hallmarks of the disease is disconnection, and that it's not just you, the physician, that can be the connecting force. I treated a lot of people with substance use disorder, and it was amazing that sometimes it was the medical assistant, sometimes it was the check-in staff that would form that connection with the patient. I had a schizophrenic patient who had a very severe substance use disorder and had been in recovery for many years, and then had relapsed, and he was not doing well when he first came back in and was pacing in the waiting room, and the check-in staff got her colleague to start checking patients in, and she went and sat down next to him until I could finish my other patients and see him. And I think sometimes it is that ability for anybody on your staff to make that connection that can be so vital, and the flip side can sometimes be so devastating to patients if that connection is not only not there, but maybe a negative experience.
Sam, do you want to go first?
Yeah. Just to circle back to what you were saying about labeling of pain patients, I'm a long-term chronic pain patient, and I was disabled for 4 years and on high levels of opiates and all that stuff. And so I don't think it's just practitioners that set patients up to be labeled. We label our pain because it helps to transmit our message so that we can be better treated. I think it's a healthcare issue, a systemic problem that we have where we identify this and we treat it with X, Y, and Z. So when we go into a practitioner's office, we present with our pain first instead of ourselves by our person. So the pain takes on this incredible identity, especially when you are disabled and you can't work. What do you do? You're a student. What do you do? You're a medical student. You're a doctor. You're a researcher. We all have these identities, and when your identity is taken away, you no longer have anything to hold on to. The only thing you really have left is that pain. So when you come in and you present, that's what's going to help you get better, is presenting what is wrong with you. So I agree that it is a total systemic issue that we have. And until my providers started educating me and treating me like a student and teaching me how to better manage my pain, I was sort of stuck in this cycle of prescriptions and, PT and all that stuff. So I don't really know how to solve the problem, but one of the best things you can do is educate your patient about how to better educate yourself as a practitioner and how to treat their pain, because they're the ones that are going home with it.
Okay. Go ahead. Okay. So hi, I'm Shelley Cohen Conrad from the Portland campus since no one can go on the Portland campus. I've been a clinical social worker for 35 years, and I'm now the director of the School of Social Work. I'm really delighted to hear the words people are using, Matt. Trust is essential, connection. But I would argue that those aren't necessarily intuitive skills. And I would argue that recognizing the beauty of the MA having the skills or the frontline receptionist having the skills is also not an intuitive knowledge that people have, and sometimes systems are designed in a way where only certain people's voices are heard. So I'm speaking to the system, not so much to the patient. So that's just a push for teaching these skills in all healthcare curriculum. And I think we kind of got rid of it over the years because the curriculum is so packed with brilliance and science and knowledge that we kind of forgot that Sam is there for us as a patient, or that I'm there as a patient, or whomever. So it's a real argument for teaching these skills. And I know Dr. Teamy and Kelly Fox have been working on those skills of empathy, compassion, connection, trust. So I wouldn't assume that they're just there. So that's just one piece. But really what I'm worried about is there are a lot of one-size-fits-all models right now out there in the community. And can I say they're making me crazy? Because they're not well designed. They're not evidence-based. They're not thoughtful. And if they are evidence-based, they're coming from, I don't know where they're coming from. They're probably, I don't even want to get into that aspect of who funds research, et cetera. But I'm really worried in healthcare that we're going to accept that everybody's the same, that how we learn to build trust, how we learn, how we open the door to every patient is a one-size-fits-all. And it really doesn't work very well. I mean, Matt, I'm sure it took you a while to feel safe with the people who were trying to provide help for you. How you feel safe and how I feel safe are going to be really different. So I'd love the panel to speak to the one-size-fits-all and what we as educators and people who design that stuff can learn from you.
Can I start? Sure. Yeah. So absolutely.
I trust you.
Thank you. I think that one of the biggest things that we discuss and we really haven't figured out how to deal with is this issue, because it isn't, one size fits all. And the big interaction that I see is the person who is using substances for treating a chronic pain, and having to work through those issues, as well as the person like Matt who took a different route into the use of substances for a different type of pain, and recognizing those types of pain. And then how do we work within that context of everybody is different, and you're not going to get one size fits all. And it is driving me crazy too.
Did anyone else want to go first? So, I am an actor. I've done improv, wrote plays, blah, blah, blah. But when I became an actor and took my acting classes and improv classes and did improv and started acting, I became a better physician. Absolutely, the skill set that I learned there could make us better. And I went to Pat Kelly. I had a session about teaching basic improv skills, and I'll tell you why in a second, to medical students. It was attended by two students, plus 2 faculty members. We're going to do it again in during orientation week, when it probably is the more appropriate time. It's more fun, but there's a method to the madness. In order to do improv, you have to be full. You cannot. When we go into a patient's office, we have an agenda. As physicians, we want to think we're going to be there for our patients, but we know we have to go through a checklist, or we know we have to make sure we ask questions about the patient's heart failure, or whatever it may be. We have an agenda, and that's important. It's very important. I once went to a meeting how you should run your office and how you should manage patients, and I said that the last thing I usually say to a patient is there anything else that we haven't spoken about that we need to talk about? And that person who ran that meeting yelled at me almost, because it's a terrible way of managing time. Well, I may not be able to, if it's something really big, but we all know that usually those last 2 minutes or 2 seconds of the visit is really the whole reason why they came. And we have a choice of either running a little late, and if I can, because of the strep throat I saw a little bit earlier, I will. Or if I can't, I bring them back in a very immediate future, because I really want to give that time. But teaching improv, you have to be fully present. And there's something called yes and. So if you say, whatever you say, I have to pay attention to that. If you say there's an elephant in the room, I don't dismiss you. I don't say there's no elephant in the room. I go, yes, there is. And I have his little cousin right here. And you work together, you connect. And I truly believe what we do as actors can help us as physicians. We don't have to all become actors, and we have to keep it real. But the secret of acting is to be real and truthful. They say that all the time, to be truthful. I don't know if we're that truthful as a physician all the time because of the time frame we work with and the agenda. We can do both. I think it's one little trick we can do to help us.
As to the one-size-fits-all system, there's an almost religious quality that I see to people's adherence to a particular solution model, which also, anybody knows someone who either does CrossFit or has gone gluten-free. It's kind of it's the same idea, and that if you do feel passionately about a system that worked for you, you kind of can't stop recommending it to people. I know people who have done radical decluttering of their house, and it's the same kind of thing. If they're like, my gosh, you should try this. I found so much stuff, and I have so much more space now in the feng shui. But I have wound up in the few years that kind of other people are trying to do treatment, because for a while it was like a few people out there in the wilderness. My first question, and I say this at the methadone clinic, and I say this in my outpatient office, whether it's a pain patient, which is the thing that's most likely to keep the person alive long enough to have whatever their next step is? So some of it is kind of problem solving. Do I want somebody to have a spiritual epiphany? Sure. Do I want someone to address their trauma? Sure. But if they're in such a miserable state right now, this may not be the time to start introducing. I've literally known people who talked to a patient who was 400 pounds and suggested, have you tried quinoa? And and it's just like, this person is not 400 pounds because they don't know how to swap up complex carbohydrates. But it's not just meeting the person where they're at, but like triaging what's the level of emergency right now. And I was on the panel for this like post-performance about Billie Holiday, and it was really kind of not what I think was. What was interesting was that the playwright had even written that he used to really judge Billie Holiday because here she was, he's a African American playwright, and here she's an African American woman, but she's using drugs. And I was like, whoa! And you're like an artist, and you feel that way. But the panel afterwards was very odd from the question answer, because there were a couple people in the audience saying, well, what really needs to happen for this heroin crisis, more 12-step. And fortunately, one of the therapists on the panel with me said, well, Billie Holiday wouldn't even have been allowed to go to 12-step because you had to be a white man to go before. And also, isn't there 12-step everywhere? And yet here we are. And then you've got people who, they want to be the savior, and they'll go, you just come in here and I'll give you this medicine and that'll help you forever. And it's always really challenging because no one has a drug problem. Just like no one has diabetes. I mean, these are not skills. If this sounds intimidating to you, buckle up, because the same thing is going to happen when you're treating diabetes, and the same thing is going to happen when you're treating. Very seldom is it a medication deficiency that is causing anybody's wellness problem. Very frequently is it there's something that's not working in their life or their emotional, or there's a resource that they don't have. But by the same token, they've usually had, like, you're not going to have somebody who's in their 40s who this is the first time anyone's told them that they need to eat more vegetables and quit smoking. So it's always going to be the same conversation, that what particular manifestation of their disease is the window dressing. It's always the same conversation of, how are you feeling about being able to take, and if it's a heart attack that you're having right now in front of me, that's a different conversation from you have cardiac risk factors. But yes, so much of it is triage, in that there's a lot of blunt instruments out there, and I would love it if there were a drug test that could tell me who's a good parent, or who has trauma, or is homeless. But there's a certain security in believing that we can do algorithm-based medicine. And what I always tell people is, research is really good at predicting what will happen in a population, but not at what will happen in an individual. And that's why knowing who the individual is, and also what baggage they already have. If you've already had 5 paternalistic doctors scolding you, I show up and suddenly I'm the countertransference object for everything they've already been through. And that's important. But yeah, there's many models, but I think first do the thing that has evidence of keeping someone alive for the next month, and from there, their brain is in a better space to actually have a conversation and be the person that they are, whatever that is, whatever that looks like.
And Dr. Norris said, meet them where they're at. I met a guy a few years ago who said, don't meet them where they're at, meet them where they dream. And I've started thinking a lot about that. In that, I used to start off everywhere I speak, and maybe I should have done it today. I'm Matthew Brown. I'm a person in long-term recovery. I'm a brother, a son, a friend, to remind myself and to remind others that I'm a person, and that I have friends and family and love, and that those are important to me. And also, I'm a person with hopes, dreams, and aspirations, to remind myself that those things matter, and to remind the world that I'm, again, as we've talked about, more than my disease, that I'm a person who wants the same things as everyone else, but maybe individual to myself. Another important role model in my life was a spiritual advisor at the abstinent-based rehab where I was at, and I'll talk about the one-size-fits-all model in a second. But he said, Matt, you'll make the world a better place because you recover. This guy doesn't know anything about me, doesn't know my story, but he knows that I landed here, and in the 50 years that he'd worked with people in recovery, I mean, he knew the statistics that not many of us make it, but he chose to focus instead of on you're going to relapse, instead of on whatever. He chose to focus, you're going to make the world a better place because you recover. I didn't believe him. I thought I deserved to be in jail. Needless to say, I thought about that, and it really resonated with me to the point that I share that with almost every single person in recovery I meet. And I want that message resonated, that you will make the world a better place because you recover. When I start to think about myself as someone who can reach those goals, I'm going to be more driven. I'm going to probably heal faster. I'm going to shift the attitudes back towards, well, maybe the world isn't this terrifying, scary, horrible place, which sometimes we know it to be. And if you as a provider, or you as a person, also sees that someone like me is capable of making the world a better place and reaching their dreams, you're going to automatically have a better attitude towards treating me and interacting with me. So meeting them where they're at, knowing it may be a process, and working with me to understand that I may not be able to immediately become a physician, which I've wanted to for a long time, that it may take steps. I may have to work at a gas station first to develop a work ethic, get a good letter of recommendation. I may need to follow these steps, but it's these many steps that can get me to accomplishing that dream. So let's shift it back towards empowerment, including in you used to say you shouldn't make changes in your life for a year. Well, there's a new emerging model of recovery called empowerment-based recovery that's occurring at all levels. It's occurring in treatment. Patients should be a part of the decision-making about his or her own care. There's a model, there's a treatment program called Life of Purpose that started in Florida, and it's now in a few other states, that believes you shouldn't have to be removed from a college setting. You should get treatment on campus and be able to continue with your education. That was unheard of a few years ago. all of these things that's allowing them to continue with their daily life and put supports in their place. The recovery community has a lot of work to do amongst ourselves. We recognize that. It's an uphill battle. I try to talk to my friends about the benefits of medication-based pathways. I try to encourage my friends to not see it as just drug replacement. It's not. It's there are many pathways. There's some great evidence now to suggest that there's many pathways, not just abstinent-based recovery. The Surgeon General's report highlights that. One of the most interesting things to the abstinent-based movement was when Hazelden, Biddeford, one of the leading abstinent-based models of treatment in the world, decided they wanted to start prescribing, was it buprenorphine or methadone? Buprenorphine.
I got the text like the day they released. Oh my God! Did you see what Hazelden just?
I mean, it's shaking
deal.
up. Yeah, it's shaking
Yeah.
up. I mean, for one of the leaders in abstinent-based treatment to say, maybe we should try something else too. I don't know if I haven't seen a report or anything on that yet, but I know they've been having good results. My own cousin went through there, and she's doing remarkably well. And so we're starting to think about this stuff. The one-size-fits-all model doesn't work, but a 12-step model may work for some. Medication may work for others. Medication and 12-step. I mean, it's wild just how many pieces there can be. Exactly. Yeah, lots and lots of pathways. So we need to shift back towards that. And
So you're saying we're not all the same?
Yeah, I kind of picked that up.
except our DNA is so similar, though,
Yeah.
right?
So is a banana.
So that's true. Yeah, so is a banana.
Since we're all ultimately going to be like looking at health.
Should he put it on here, because then they won't hear it in Portland?
Is this on?
I think so.
Hello. Since we're all going to be ultimately trying to help people with addiction one day, I'm wondering if you could give some personal information on barriers you faced when you were when you were in recovery, what things that you might have found frustrating that we could ultimately try and help fix one day.
Do you have about 5 days to talk?
Sorry if that was a loaded question, but yeah.
We can certainly start this conversation. I'm happy to share my contact information and talk more a lot afterwards too. But here's a fascinating example just to share. I mean, this is of course this is just one big example. There are lots of other small examples, but a good friend of mine got an internship at an executive office of the president, the White House Office of National Drug Control Policy. So he went to D.C. He had the highest security level clearance in the country, in the world. And yet his landlord wouldn't give him an apartment because he's a convicted felon. So that was powerful. And he was like, I can get a letter from the president saying that I have security level clearance. So he found an apartment, but he had to go through many, many different hoops. So despite success in one area, perhaps, of a system, we can still have these discriminatory policies all the way up through that. And so we need to do better education and empowerment and storytelling to show there's living proof and show that people should have these second chances, and that, I mean, many people in this world are given many, many, many second chances. Let's think about that and offering a second chance to someone else. So there are barriers to getting jobs, even simple entry-level jobs, barriers to housing. There's barriers to, a lot of other things, in that until we shift this attitude back, it's going to be hard for them to navigate this. So we're getting a lot of employers to come out on record saying, I will hire a person in recovery now, and making stable housing affordable and accessible, just as a few examples. I hope that's helpful.
Additional barriers when I first started doing medication-assisted recovery. And you'll notice I'm saying medication-assisted recovery and not medication-assisted treatment, because I think we're a team. I'm not showing up as the benevolent fixer, what somebody calls white savior Barbie. And we had to have a meeting with my then office in Blue Hill so that everyone was comfortable with the idea that we were going to have those people in the office. And then after we did it for a while, the staff started realizing that the population in the waiting room hadn't changed appreciably. As recently as 4 years ago, I was notified in the beginning of January that I had to be out of my office, which is actually a building that's owned by an osteopathic physician with affiliation with this university. I was notified by email I had to be out by the end of the month because my practice was not appropriate for the setting of this building. And I thought it was one of those, is this the mountain you want to die on kind of thing. And I just said fine and moved. As recently as last May, the Kennebunk has a May Day parade every year, and I got a bunch of people in recovery together who were going to do the Recovery as Possible thing in the parade. And astonishingly, I was told, well, although the work you do is so important, we just think this really isn't the right setting. And I gave the world's most carefully worded response, which was, well, huh? No, well, because I thought at the end of the day, what I really want is like, my folks who were going to be with me, including like the CEO of our organization, like, it was more important to me that we get out there, and I had already had to explain to my patients that I got evicted because of, basically we're all dirtbags and our kind doesn't belong here. But I just really, so I carefully, and they said, thank you for understanding. And I said, I'd like to understand. Please explain to me because I know the recovery community really looks forward to a long relationship with the rest of the community, and if there's ways we can make people more comfortable. And I'm thinking, screw you. If this was cancer, you'd be wearing a ribbon. But ultimately, we were able to do it, and we pulled my dog in the red wagon with a label that said "Pugs, Not Drugs," and it was very well received, and people liked it. But that's like, just to be in the freaking parade as people associated with recovery, saying recovery is possible. So, and that's none of this is even close to the stigma that people face when they're themselves in recovery. I mean, we were being advocates, but one thing I will always say is that if you are in the emergency department doing a surgery, treating somebody for a strep throat, and on their med list is that they're on buprenorphine, they're on methadone, they're on whatever, the only thing that should be coming out of your mouth is, good for you, how's your recovery going? That's so awesome, what's working for you? Like, so many of my pregnant folks get like insta-flinch when they go to their new provider for their OB, and that's on their med list. Suddenly the whole conversation changes. Suddenly the midwife is creeped out. Suddenly the nurse is whispering to and these are people who've been sober for like years, and they happen to be having a pregnancy with their long-term partner and blah, blah, blah. It's, never mind access to treatment, which is also limited, never mind understanding, never mind, but simply even for me to be allowed to treat people in a building owned by a fellow osteopathic physician has been a challenge as recently as 4 years ago. So.
I just want to quickly piggyback on the medication thing for a second. I had a great conversation with Harmony. I guess she left or stepped out for a second after a conference on Saturday. The recovery community, a lot of the hardcore 12-steppers will, if someone's on any type of medication, whatever it is, mind-altering or not, but especially the antidepressants, antipsychotics, and the methadone, buprenorphine, the recovery community is going to say you are not in recovery, and we shame within our own community. It's awful, absolutely awful. One of the best things you can do as a provider, it's very simple, is you can say you are in recovery. And just like Dr. Norris said, make them believe they are doing the right things for their recovery, whether they need medication or not, whether they want to be on medication or not. You can be that powerful influence and support, and to make them feel safe when the rest of the world might not make them feel safe.
I've had people sponsor actually tell them after 6 months, you and I both know you're not really sober. And I suggested, number one, get a new sponsor, and number two, ask them if they would like to manage my mother's hypertension and my aunt's diabetes, because clearly they're experts on this.
One of the frustrating things being in primary care, not frustrating. It's just simply the truth. When you send people to any specialty, that's their area of expertise, and there's a level of commitment, hopefully on the patient's part also, whether you send them to a cardiologist, whether you send them to a physical therapist, whether you send them to a counselor, whether you send them to a recovery specialist. We see patients at many different levels of wanting to change. Most commonly, they do not want to change, and that is our challenge. Yep. And when someone comes in, I guess one of the first things to identify, a patient may identify that they have a problem, and that's easier because unless you buy into whatever issue you're talking about, no change is not possible. The trickier thing is when you recognize or you assume or you think there is a problem, and sometimes everything is shades of gray, but some are closer to black and closer to white than others, is knowing that you are not going to be able to change that person at that time. I have one patient who has gone to recovery centers on both coasts. I think he has went and either left early, been found on the side of the road, have come home, went back. Again, all over this country, maybe 6, 7, 8 times. He has been with medication, without medication. He is very well aware of his behavior, that he undermines any approach. And he does not know why he does it, except he knows that when he is drinking, in this case it's drinking, he feels better. And as a physician, as his primary care physician, as someone who's known him since he was a teenager, I feel useless. But we say, at the end of every visit, we say, I love you. I love you too. We hug. And I don't even know where I'm going with this, except that our battle as a primary care physician is often so very different from yours. And I'm primary care too. Oh, great. Yeah, that's right. And we know we're going to fail. Mm-hmm. You know, they talk about baseball. If you fail 7 out of 10 times, you are in the Hall of Fame. I wish I failed that infrequently. And I know we're not failing, yeah, but man, it feels like it.
Yeah, it's only failing. I'm sorry. You know, when I was, Maine Small, so you wind up being president of a number of things. When I was osteopathic family medicine, one of the things that we always talked about is that surgeons have a scalpel and family physicians have a relationship. And internists too, although my husband's an internist, I like to make mean fun of him about that. You're failing if the person leaves feeling dehumanized. You're failing if the person leaves feeling hopeless, if they're feeling that you weren't listening to them. If we're attached to some kind of outcomes-based metric, I mean, I don't have the juice of immortality. Every single one of my patients are going to die. I'd rather some of them didn't die at the young age they're dying, but your failure is in your lack of connection to an individual. It's not in your magic bullet. It's arrogant for us to believe that we are fixing anybody. And just like I tell the people in recovery, you don't have the power to ruin everything. So, at the end of the day, I'm a person, they're a person, and the other people they're interacting with is a person. If any of us walk away not feeling like regular human beings, then that's where the failure is.
So we don't have a ton of time left. I just want to open it up if anybody has any specific questions that they want to ask. And I think
So I want to go back again to Matt, the concept of dreams. So in the student behind who's, I can't, there you go, say, well, what are the barriers and providers? And I would say the first step of eliminating the barriers starts with you guys, because the system is terribly broken. And, you know, I think hearing you guys blame yourself and feeling shame makes me feel sad, because it's not your fault. You're in a system that says you only have, you know, get your hours out, and when you've got a patient in front of you who you really need to spend extra time with, you know, you're limited by those checklists. You're limited by a system that is about, and excuse me, I'm a social worker, I think I already said that, so you'll hear this, but you're limited by a system, and then you're made to feel bad about yourselves, which is sort of parallel to how people who are struggling with substances are, you know, you're dealing with life is hard and being human is difficult, and substances have given you something, or have, for whatever genetic reasons, become part of something you depend on, whatever it is. So I look to all of you to think about how do you look at yourselves and think about how can I do a better job and create an atmosphere of trust for any patient who comes through. And kind of be aware of your assumptions, because you're going to have them, but you can't do them in the office. I mean, you can do them at home, but you can't do them in the office, or at least you need to be aware of what they are. And the second thing I would say is work to change this system, because it's not working for you. It's not working for them. It's not working for you. It's certainly not working for me as a geriatric patient. I can tell you, it's a mess out there. And I need help. So, anyway.
One thing I want to add is that despite this feeling of failing over and over again, and the system's broken, is that I love what I do. I absolutely love this.
Can I say something first before you, to go back to what Shelley said and what, I forget, what's your name?
John.
John. Okay. So at this school, what I've been learning from listening to the students and interviewing potential students is that we have a culture at COM that encourages collaboration, and does not encourage isolation. So I think that I'll label myself as a mentor, and I'll label you guys as mentors, and some of you over there too, that we have an obligation to live into our role mentoring this culture that inherently should bring about change, because I think humans living in isolation seek to self-soothe, seek to heal in isolation, which would look very different than doing it as a community. And I think some of the communities that have lasted over time, whether it's the Jews or the Greeks or the whatevers, demonstrates that community really does raise a person in a more holistic way. And so I think that you are part of a community of healing and change, and that we should nurture that.
I do think collaboration is huge, and there are lots of trained professionals, not just medical professionals, who have unique skills to address some of this. But with team-based approaches comes more burden on the patient's pocket, and we need help figuring that out. Funding is a huge issue, and I'll quickly share that my own insurance denied to pay for my life-saving treatment for a whole year. And my parents and I are fighters, and we were not willing to let them get away with that, considering they never had a conversation with my parents or me. Didn't look at my files, kept saying that they lost my files. They kept saying it's not medically necessary, and my dad especially kept pushing and saying, you put me on the phone with this person who said it's not medically necessary, and they wouldn't do that. Maybe. So no addiction medicine specialist from the insurance company actually looked at my file, never had a conversation with me, but yet we persisted, and after a year, when they lost and my files again, and basically that meant that they were going to push it up to the state, and the state then had jurisdiction, we won and we got full treatment, but still there was no addiction medicine specialist on that panel review phone call that we had, and this actually turned into one of my essays that I used for my med school application in fighting systems. But that's a big problem, and I'm prepared to take on insurance companies on behalf of my patients someday. I hope you'll be willing to do that, and if anyone wants to take on the great advocacy cause and changing insurance practices, let me know. I hope to address that at some point in my lifetime. But these the money's tough, and we need you to be a great advocate for us because we're terrified. And even if you're scared too, well, let's figure it out together.
Be prepared also to be advocates in terms of the pharmacies. When some of the prescribing laws were changed in the in January because of our beloved leader, I wound up having to actually say, if any of you put signs in the office, I called, tried to advocate, wrote letters, called, spoke to the pharmacist, tried to reassure them. One particular organization was routinely shaming my patients, both the pain patients and the recovery patients, routinely talking to them like in front of other patients in line at the pharmacy, having a lot of editorial remarks, including about me, that, boy, it doesn't seem like she planned ahead very well. And I finally put a note, I know, I wound up having a note in my office saying, go wherever you want for prescriptions, but if you want to go to CVS, we're not helping you do the prior authorizations. Because I was tired of having to go on a scorched earth campaign every day. That sign was up for about 2 days before corporate called me. And then I was talking to the Board of Pharmacists. But like the great thing about Maine is you can talk to the chair of the Board of Pharmacy. You can talk to the medical director for DHHS, Chris Pizzullo. He went here, I believe. But remember that no matter how intimidated you are, you're still in a position of relative authority and power compared to people. Not everybody is going to have the level of self-advocacy that Matthew's family had. Some people just will slink away and not get treatment. Yeah, that's exactly what they want. Additional PR. For those of you who are the PG2s who came to the lecture, why don't we say narcotic? Why do we say opioid or controlled substance? You're breaking my heart, guys. So a narcotic is the thing that you get arrested for possession of. It's not a medically pertinent term. So if you have a patient that you refer to in your note, your discharge summary as high doses of narcotics, you're helping perpetuate the idea that this is a criminal. Why don't we say marijuana? Somebody must remember this. I made a big... Okay. You going to tell...
Step up to the mic. Oh, good. Just careful. It was, I think you said it was sort of a race-based way of getting people against marijuana, was tell them that the Mexicans like it.
When Prohibition wasn't getting enough traction, according to the federal government, they started focusing on other mind-altering things, including cannabis, and they created a whole narrative where it was brought over the border by these scary Mexicans. And so it was a way of race baiting and making people not only more afraid of brown people, but more afraid of this, because this is what jazz musicians and Mexicans use. And so we call it this. It is. So we call it this exotic. If you also are fans of contemporary swing, the song Zoot Suit Riot is about a similar phenomenon, which is that we should be scared also of swing music and zoot suits, because that's what the Mexicans wear when they come across the border to date our white girls. I'm not making this up.
So if I could just have you guys leave us with maybe a couple of words or a couple sentences of what we should take away from this. I know that might be difficult.
Treat addiction, save lives. Addiction isn't a crime. Substance use disorder is not a crime. If this was heart disease, you'd be having a walkathon.
Instead of summarizing, I want to add one more quick thought, because we didn't talk a lot about language, and we can share a lot of information with you about appropriate words to use, appropriate words to discuss, other things we should elevate or discontinue. But I'll share a little bit of a quick case study about about language in the medical community that was written by John Kelly and Sarah Wakeman and maybe others in Massachusetts and Boston. The term substance abuser and the term person with a substance use disorder, that was the only difference in this study. And 500 doctoral level mental health clinicians were given this vignette of a man who needs treatment, had been using drugs and alcohol for a few years, was court mandated to this treatment and had been following the protocol and procedure. And in about 30 days, he was found to have tested positive for substances, and that was against their requirements. So he was again in front of a judge. What do you do? The people who saw this man as a substance abuser, and again, these were medical professionals, were more willing to deny treatment, which is discrimination. They were more willing to see someone as not deserving of their care. Again, that's a stigma. These are bad things. This isn't what I want out of a medical professional, but there's incredible implicit cognitive bias. Those are the words that John Kelly likes to say, and these things, these attitudes, shape our policy. And the person with a substance use disorder was when they saw him as a person with a substance use disorder, was more willing to give the appropriate care. So this is really powerful stuff. And of course, that trend is much more powerful in the general community, but among medical professionals, they're worried about someone with a substance, seen as a substance abuser. And we know that word abuse is just an awful word in every sense of the word, so let's not associate that with this substance use issue.
So thanks, everybody. I'm glad we got a full crowd in here today. Thank Nicolette for organizing it and the clubs that were involved with doing that. It would have been nicer if we had been able to open up those folding the wall and had the place as full as this, all going all the way back, all 380 medical students, 360 medical students that are on campus, plus other undergraduates that are here. So this is only a small group, so keep coming to things like this, because it is a matter of practice and discussion and learning skills about how to work with persons with substance use disorders. And thanks for being here.
You're welcome.
All right, thank you all for coming. Remember to take some food.